All right. We're going to stop at the top of the hour. We always have enough announcement pages, so I'm sure we have time for everyone to roll in. Again, this is Sarah DeSilvi. Welcome to the September 17th Gravity Project public call. This is officially the transportation kickoff. We'll detail and our subject matter experts when it comes to that time, but we're just going to start going with the rest of our agenda, and thank you all for coming. Next slide, please. I just want to, again, formally welcome you. I do want to state that we have a pretty robust chat feature. So we mute everybody upon entry. Those of you who've been in calls before know that we unmute when we have an opportunity to have a collective conversation. But I read the chat pretty religiously and try to integrate chat comments into the conversation. So please use the chat feature, send your chats to everyone, and then we will make sure they're integrated. And then we have a really clear policy now that if a question does not get answered in the chat, we review it, and then we'll be sending emails out after the meeting to make sure your questions are addressed. The call is recorded, of course, and all of the calls are available on the Gravity Confluence page after the meeting. Next slide, please. This is a necessary antitrust practices slide that we have to give in front of every single meeting. Next slide, please. If you are joining and are not already an official member, we always post this link here, which is the official joining the project. Of note, we're going to be working this meeting to try to preempt all of the links in the chat feature. So if you don't see the link to join, you might see it later at the end of the homework. And no, here they are. The links are coming because we're trying to anticipate that as we send links and talk about links in the conversation, you will want to access them. So if you want to check whether you're already signed up or if others in your organization are signed up, you can review the membership there. And then the Confluence is always the place to visit to get any and all information. It is robust. It is sometimes overwhelming, but it is all there. Next slide, please. Just a formal thank you to all of our project founders and in-kind supporters. We are incredibly grateful to all of you.
Welcome to WebEx.
Welcome to WebEx to you. And so just a note of thanks. Next slide, please. Again, if any of your organizations would like to sponsor the Gravity Project, this is the link to follow to do that. Next slide, please. And then Evelyn, do you want to take over this? This is our working on the US CDI submission.
Sure. Good afternoon, everyone. So just quickly, we've introduced this previously, but a reminder to all that follow the ONC United States Core for Data Interoperability. Submissions are due October 9th. We've been working in the background on how we will submit the food insecurity data elements that were consensus informed or built by this community. So if you are interested in, we've received lots of interest. I do want to acknowledge that we've received lots of emails from individuals and organizations that want to be involved. So send us a note and stay tuned because we will be presenting our approach. So we are a transparent process, so we'll let you all know what we will be submitting, the approach we will take. And then if you want to be part of the attachment letter, let us know. Thank you. Back to you. Next slide. Sorry, next slide. Probably me. This is just a reminder, ACL Challenge Grant applications are due, well, the letter of intent is due at the end of the year, and these are funding available for testing next year, the Gravity standards. Next slide. And a heads up that ONC, so for those that are not aware, ONC has an SDOH workshop they have scheduled for this next Monday. We have our presentation time at 10:40. So this is a free workshop for those interested. Lots of good topics. Please peruse the agenda and the registration. Next slide.
I can't I can take this over. So so one of our members, lovely Lucy Johns, was wondering whether access had changed because it was hard to get into the meeting. Nothing changed on our side, but these platforms, I feel like they're constantly evolving and learning different snags. So I hope individuals, when you enter, please report any concerns to us, and we'll try to bring them up. So this is the agenda for the day. Evelyn's going to briefly present on our new Gravity roadmap and some upcoming domains. We'll talk about the project schedule and then just briefly overview terminology approach. I will go into the consensus voting on housing instability and homelessness. Then we are super honored to hand over a presentation to Jen Sisto-Gall and Alex King, who will kick us off on transportation. I will then come back and talk about the inadequate housing concepts and gravity principles. We'll then pass over for a debrief on the Connectathon from our technical director, Bob Dieterle. Busy agenda. I promise we'll do the best we can to get through everything. Next slide, please. So Evelyn, this is your masterwork. Do you want to take this over?
Yep. So this is fresh. We just developed this. So we're super excited to let our community know that we have established a roadmap for the end of this year and next year. So what you see here is a very busy slide, but it's really to inform you all that we have identified the new domains we will be working on in parallel. So super exciting work for us. We'll present in the next slide, go through more the details of what the domains are. But as you can see here, this new timeline, for those that have participated in our other meetings, you've seen that we always work, and Sarah will introduce our two work streams, our technical and our technology. Sorry, and I'm just saying terminology work streams, and they've always worked hand in hand. And Bob will spend more time going through recapping the technical work stream. But what we want to show here is that we are going to continue working on these in parallel. We have a set of domains we will focus on, and then in parallel, and then we will continue doing single domains. So there is I'll explain that we will continue doing one domain at a time for goals and interventions, but multi-domains for screening and diagnoses. At the same time, we'll continue with our Fire IG. The Fire IG will initially incorporate food insecurity, but it will be designed to rapidly integrate these multi-domains. Bob has presented and will present today that it is designed for multi-domain data capture. And then we are excited to announce our new work stream. So stay tuned for our pilot. So at the bottom, you'll see that we will start working on our pilot phase next year. The pilots will be designed to test real time the Fire IG that is scheduled to be published in May of next year. So we will coordinate, we'll have scheduled pilots. So please stay tuned for that. No details, not yet. But that's not to say that what we are developing can't be tested in advance. It can. It's just acknowledging that we will have a formal pilot phase next year. So stay tuned for that. Next slide. So I just recapping from this is the domains. So So here are our domains. Since we kicked off in 2019, we emphasized the three primary domains of food insecurity, housing, and transportation. Since then, we've divided them, made them clear. So housing broke up into housing and homelessness and inadequate housing. And today we kick off transportation. Next month, we will kick off financial strain and demographic data. And in January of next year, we'll work in parallel for social isolation, stress, environmental safety, and violence. As I mentioned in the previous slide, for us to do these in parallel and also be cautious of your time, we are only going to focus on, as we look at the circle that we show all the time there on the right-hand side, we'll focus on just gathering the screening and diagnoses data concepts. So we'll go through our whole process, and Sarah will speak to this. We'll continue doing what we do, but we'll focus screening and diagnoses first for the multi-domains, but we'll continue goals and interventions one domain at a time. So we're going to try, this is our roadmap for the year. Super exciting, a lot of work. But we will try to get this through. So next year we'll have multiple new code submissions at one time. And with that, I'm going to hand over to Sarah, because it's a brilliant mind that came up with this, schedule and a domain. So Sarah, please chime in.
I would actually say that it's our collective mind that framed this, because if we look at phase 1 and phase 2, and the work we've done over the course of the last year and a half, we've basically been framing trying to structure the risks in concentric circles of like what happens inside my house, what happens as I interact with individuals, and then what happens as I interact with the environment. So we're just we're continuing that structuring that way. So phase 1 are the economic drivers that are within the individual environment that I live in. Phase 2 are interpersonal social risks that happen when I interact with other individuals. And then there's a placeholder for phase 3 that is not on here, which are some of the concepts that we did not address yet that have been kind of putting into our future work, which would be conversations regarding neighborhood safety or food apartheid or the intersections of individual and their greater environment. But this is just representing actually the collective framing that we've come up with, all of us, all 1,000 of us, over the course of the last year and a half. And again, this is just to structure our work. And we've already, that framing might be challenged at times, because certainly as we go into transportation, as the SMEs discuss, we will also let the SMEs decide the limits and boundaries of that domain as we go forward. Lucy has a question here. Will fire IG pilots be transmission agnostic? I have to admit, I don't know if I understand that question. I'm wondering if that question is good to save for Bob when he comes on at 5. Yeah. Is that okay? Thank you. Because I can't answer it well enough. All right. Any questions on this framing? All right. Put your seatbelts on, folks. It's good. We're doing, we keep on adding work, but I think we're refining our processes too, and it's very exciting. And one of the things we keep on talking about is none of these domains actually really occur in isolation. So as we kind of apply domain upon domain, we're actually kind of better representing the experience of the individuals we care for that don't have any of these domains in silos. They're actually complex Venn diagrams of social risks. There should be a lot of sharing of information across the SME groups as well, which I really look forward to. Next slide, please. This is just a statement of where we are again. So September 17th, we're finishing voting for housing instability and homelessness. We've extended it because we need to hit our quorum there. We are reviewing some inadequate housing data element concepts. We're kicking off transportation. So your homework in that right column is submitting your votes for housing instability and homelessness, submitting your concepts for inadequate housing, and submitting your concepts for transportation. Each of those activities can be found on the Confluence. And again, specific links to those will be available as we review those slides in our presentation. Next time, we'll be going into the end-to-end review for inadequate housing and closing the end of the voting for housing instability and homelessness, which is again extended into October 3rd. Next slide, please. Mike Klinkman says, seems to me this approach fits better with the plans, preferences of POs and medical payers to move on several domains in the very near future. Mike, you are correct in assessing that. Yeah, so one of our tensions is I feel like we have a process by which we can ensure the rigor and practical vetting of our terminology concepts while we move forward in creating some of the diagnostic and screening language that needs to be implemented from a public data aggregation level. So again, we're trying to meet the needs of multiple stakeholders, and we'll do our best to make sure that the rigor and practicality and fit and like elegance of the terminology we're creating is kept intact. This is just our two streams again. So terminology and technical and how they integrate in the middle. We see this every week. I'm not going to talk about this too much. Next slide, please. We've added some little icons to our community terminology development process, thanks to the insight of one of our dear friends, Greg Bloom. So the phases we go through in our terminology development process are basically pre-work of identifying subject matter experts and then collectively identifying the terminology that needs to be created. We then review it as a group. We then vote on it. We then work to build these concepts into the terminology organizations that are our partners that we're very grateful for, whether it be SNOMED, CT, LOINC, or ICD-10-CM. Then comes the next phases, which is real testing now, as Evelyn was talking about, and then the more formal pilot work that's happening in 2021. All of these processes allow for an evaluation and feedback loop so that we can ensure that we are iteratively reacting to the concepts we're building. Yes, and Mike Klinkman says, on this approach is also in keeping with our goal of not moving prematurely into interventions with payers. And I want to say this process also allows us to iron out some of the complexities of terminology intervention build, which actually really makes sure that we collaborate with our community partners in order to create concepts that are actually useful and practical for our community. Again, we say in Gravity that we may identify these problems in healthcare settings, but they're largely solved in communities. So we don't want to proceed boldly with intervention language that doesn't meet the needs of our community members. Next slide, please. Okay. Any questions? I think we're doing good. Okay, next slide. All right, urgent plea. This is one of Sarah DeSilvi's urgent pleas. Consensus voting on housing instability and homelessness. Next slide. So again, this is just an honor and gratefulness to the housing data element submitters. Next slide. This is the table of where we stand. So we are urgently asking all of our committed members, and again, you can check whether or not you're a committed member with the link that Sarah B presented at the top of the slide, to vote on the housing instability and homelessness data set as it stands. This data set's not complete unless we have a quorum of votes. So although our group is 1,000 strong, what we are focusing our voting on is at least consensus of those signed up for interested in the housing domain. That total count is 239. That means we need 120 votes, and those votes just need to happen. They don't even have to be all yes, go. Just to represent consensus, we need 120 votes. We've only gotten 28. So we need at least 92 votes to get to the end of this consensus voting process. So please check your membership. If you're a committed voter, place your vote. And then we have until October 3rd. Next slide, please. I just want to remind folks again what the voting options are. Yes is yes, bless it, it's all good. Yes with comment is yes, but, like yes, but I think this should change, or yes, I note this risk, or whatever you want to say. Formal objection is as it stands, and an abstain is a member declines. So again, we're seeking about 90 more votes to get to our quorum. Anyone who's a committed member on the call, please vote. And if you have members of your organizations who you know are also committed, but they're not on the call today, please get out the word. Thank you. And this is the final step of that amazing work that we just did over the course of the last few months. Next slide, please. And there's a little word cloud. This is my little homage to Lucy. Next slide, please. All right, any questions on the voting? Oh, yes. Yeah, so Lucy is urging us, just like your public radio telethon. You can vote now while listening. Go. Thank you, Lucy. uh, next slide, please. Transportation kickoff. It is now my honor, and Linda will help pass the mic. Oh, yes, Mark is saying announce at the end of the meeting what the vote is so far. I'll see if we can do that. That's asking a lot of our team that's running the presentation. But yeah, we'll see. So it is my honor to present our transportation domain subject matter experts. We are really quite lucky to have Alexandra King. She's a public health and transportation policy consultant representing the Community Transportation Association of America. And then Jennifer Sisto-Gall, who's a senior manager in business development and healthcare at Lyft. I'm now going to mute my mic and pass the mic. And again, we're very grateful. I do want to announce actually the one late breaking new SME that you'll be introduced to next time we come back. So you'll meet, the SME group is actually probably going to acquire a couple more SMEs to the group over the course of the next couple weeks. Okay, Alex and Jen, thank you so much.
Awesome. Thank you, Sarah. Hopefully you guys can all hear me now. And Jen, I just want to make sure you're unmuted in here as well.
Hi, I'm here, Alex. Great to be here.
Perfect. All right. So we can go ahead and go to the next slide. I know we have a lot to cover. And Jen and I would love to kind of run through this and make sure we have time for everything else as well. So today we're going to kind of provide the overview of the domain and try and give you a sense of where there is information and where there's a few gaps in the current knowledge in the space. But kind of kick us off, generally the discussion of transportation and health, it's not a new link. It's kind of been going on for a long time. Non-emergency medical transportation has existed since the Medicaid program's inception in the 60s. So for those of us that have worked in the space, there's been a lot going on for a long time. Next slide. Great. So as many of you probably are aware, the lack of transportation affects access to medical care, as well as economic opportunities, healthy food, and other resources needed to be healthy. Because of this just wide variety of ways in which transportation affects both individual and community health, I like to use the term universality of transportation, because when leveraged, transportation really can play a large role in the health and well-being of our communities. And as you can see, I kind of split it into 4 buckets here: access to healthcare services, access to health-related services or social determinants of health, the impact on community and individual health, and then the impact on environmental health. So next slide. Great. So as I said, health and transportation originally kind of existed within the idea of NEMT. So, and NEMT is non-emergency medical transportation, which is often used synonymously with the Medicaid benefit. However, as we've seen in the past few years, it's really expanded beyond that to exist as a general service that can be provided for anyone who has transportation barriers in their access to care. Between these 2 slides, you can see historically that TRIP, whether in Medicaid or elsewhere, existed as a way to get people to the hospital for their appointments. However, with the growing kind of understanding and support for social determinants, we're seeing the NEMT trip really expand into a lot more destinations. So, you know, we haven't seen that in Medicaid yet, but in a lot of other payers or insurers or programs, transportation is now being used to provide access to hospitals, pharmacies, social services. There should be another arrow going to behavioral health on that diagram as well. So on that note, if you can go to the next slide, and sorry, I don't know if I can switch the slides, can I?
Unfortunately, Linda's running them, but thank you.
Okay, perfect. So to kind of build off of that, connecting transportation and mobility and social determinants of health really is an opportunity to connect the dots. For those of us in the field, it's a really exciting connection that we're seeing, because connecting these ideas just builds the ways in which we can improve individual health. You know, as you can see there, kind of transportation is not only a singular social determinant, but it also can connect individuals to other social determinants. So it has this kind of like growth and kind of hyperbolic effect when you can make sure people have access to it. Next slide. And then the last piece of kind of giving a really baseline definition of this field is thinking about how we define a transportation barrier or transportation insecurity. That kind of is at the base of this work. And, you know, Jen and I had a lot of conversations with Sarah, and there's really not a standard method that exists at the moment to define what a transportation barrier is. And I think that's because it's so different for every person. So on this slide, we've put together kind of a list of commonly used factors that can exist within the general kind of definition or bucket of a transportation barrier. So that includes time spent traveling to a healthcare provider, distance between patients and available healthcare facilities, existing transportation infrastructure, whether that's a personal vehicle and whether or not an individual has that, or public transportation infrastructure, the cost of these transportation services or infrastructure, knowledge, perception, and use, and then also appropriateness of the models or modes that are available for the individual that needs it. So kind of we can dive into these more later. I want to stop real quick to see if Jen has any other comments on the definition part before I jump to our next topic area.
I think very well covered, Alex.
Perfect. All right, next slide. Great, and you can just go to the next one. So kind of this next piece, we want to talk about how we define and discuss the impact of transportation on health, or the value that transportation can provide to both individuals and healthcare providers or insurers or hospitals. So this is kind of a large, many of the numbers you'll see here are the main numbers available. This is another area where there isn't a ton of studies available. We're seeing more and more come out. Even this 5.8 million number, this was just updated. You guys probably are more familiar with the 3.6 million figure that has been used with regards to people who can't access healthcare. So now that isn't updated as of 2017, we can say each year 5.8 million cannot access healthcare. And that lack of access creates a lot of challenges, including, you know, poor health outcomes, diminished ability to provide preventative care or monitor an existing condition. And it also can increase costs overall due to missed appointments, unnecessary readmission rates, or, you know, that delayed care. So that has resulted in a cost of $150 billion annually to the U.S. healthcare system. And that number is just missed appointments and care delays, not even some of those other health outcome things that could be kind of folded into that. Next slide. So, and this kind of goes to the important role that transportation specifically plays. So in a study completed by McKinsey, some of the largest cost drivers can be linked to unmet transportation needs. So as you can see the numbers on this slide, those with unmet transportation needs are 2.6 times more likely to report multiple ER visits and 2.2 times more likely to report an IT visit over a 12-month period. Jen, I don't know if you're more familiar with this study and you want to add anything else on this?
Yeah, I think it just speaks exactly to what you were speaking about earlier, Alex, on those downstream impacts. And this can't be more obvious of the cost. Certainly, we all can think about the cost and health impact of someone needing an ER visit or an inpatient stay when those could be avoidable, right? By getting that upstream preventive care, or for example, with an ER visit, was it a trip to the grocery store to get healthy and nutritious foods? Now, those things are extremely hard to measure, right? And to parse out and say what the exact effect is, but do think that this just really brings it home of that kind of hyperbolic nature Alex was referring to earlier, and that we do see transportation in the small amount of literature that we have today, and a lot of it is gray literature, frankly, but there are some pretty strong reviews, and the next slide Alex will cover is a very strong piece in this field, is what are the specific kind of patient cohorts, conditions, and just individuals who this transportation barrier really impacts their health, and who really has the transportation insecurity as a social risk factor, so that we can bring those interventions upstream and look at avoiding these types of negative costs to the system, and of course, negative health impact to the individual.
Great. Well, you teed me right up, so let's go to the next slide. Great. And so, you know, as Jen was talking about, this is a review that's a couple years older now, but really looked at the relationship between transportation and the use of NEMT services for chronic disease management and preventative services. And it found for a lot of different both preventive and disease management care that transportation services can help things to be cost effective or even cost savings. So those are kind of the two buckets there. I think there have been even more studies that have come out recently on the return on investment of transportation. You know, I think specifically for end-stage renal disease or dialysis treatment, that has continually kind of shown. And even I know some studies are kind of starting to look at behavioral health as well. So at this point, I think we've covered a really good sense of kind of the limited data that is available. We're really excited to step into the domain and kind of continue to build this and see what else other individuals can share. So Jen, I'm going to turn it over to you to talk about screening now and kind of assessments and what we have available.
Great. Thanks so much, Alex. We can go to the next slide. Okay, and next slide. So in terms of the current screening approaches, as I mentioned, when we think from a kind of public health, community health perspective, and we really want to understand what is the exposure of transportation and the outcome, you know, one thing that I think a lot of has been emerging in the field is we want to make sure, first of all, that someone has an existing transportation barrier or an issue with access to care or other health related services. But as is common, I'm sure, across all the previous domains, there are several screening tools that are out there. So of course we have Prepare, tools such as AHC, which have, and health related social needs screening, which have been adapted from Prepare. Further, you know, the recommended social and behavioral domains, the health leads tool. And then in terms of some of these less known screening tools, we can look at the FENEC social determinants, or even that last linked screening tool. So I'll let Sarah chime in on any other specifics, but I think for me, the takeaway here is, you know, this is an area of need, an area of impact. Yes, there's been a proliferation of tools. I think every person on this call is here because we see the urgency and the opportunity to bring these together and better have a full cycle understanding of, you know, how prevalent are these barriers for which types of cohorts and for which do interventions really matter. And crucially, of course, there is no ICD-10 code, which is specifically for transportation. I think that's a big call out and gap in the space. Sarah DeSilvi, did you want to add anything else on just the screening tools that are out there?
No, I think, of course, you covered it so elegantly. So I think, again, Prepare is kind of the anchor, as it is in many things. I do want to note that so there's a proliferation, but it's not quite the cacophony of tools that we have in the food insecurity space. So it might actually be easier to create, we have an opportunity essentially to create consensus on a path going forward here, which I think is actually kind of lovely. And then the other thing I want to note, so I do try to feed the, bring in comments from the chat. So Lucy is just asking us to recognize that availability of transportation can also result in access to unnecessary care and unnecessary costs. So that balance between, you know, access being, access concerns driving delays or gaps in care. And then certainly the mirror of that is when you have unnecessary costs and unnecessary visits. And Lucy, yeah, we do try to keep that lens in line, especially from a triple lane perspective, as we try to make sure that we're improving patient outcomes, decreasing cost, et cetera. So absolutely. So Jen, that was answering your question and answering the chat. I hope that was helpful.
Absolutely. We can go on then, unless there are any other questions on the screening approaches to the programs, where I think we'll spend a bulk of use case and programs. Can we progress the slides, please? Fantastic. One more. All right, so bringing it back to the different connection points and the roadmap Alex, pun intended, had laid out at the beginning. we can think about breaking down use cases for transportation and access to health in kind of these 3 buckets. Largely, it's getting people to care they need. I appreciate, Lucy, your context on avoiding unnecessary utilization. I think that just goes back to, again, screening folks who actually have a transportation insecurity status and need that exposure of transportation, need a benefit, need a support and service. But so we have getting people to the care they need, and then we have getting care to individuals. So in that first bucket of getting people to care, whether it's medical or non-medical, we certainly have rides to and from medical appointments, rides to and from clinical trials, rides to and from the pharmacy, and then those non-medical rides, quote unquote, which you might like that phrase or not, to and from other social determinants of health. Or kind of, I like to think about these as interventions or rides that can bring together multiple social risk factors. So if you are both transportation, food insecure, and potentially socially isolated, getting a ride to the grocery store can actually help with all 3 of those things, right? You're getting out into your community. You're able to, shop for nutritious foods with adequate supports and services, and even get some physical activity while you're at it. So then caregiver travel. So clearly getting caregivers to where they're needed. Home-based care, certainly a part of this, or other site-based care. We can think about schools or other kind of pop-up types of caregiving situations. Another use case that we've certainly seen in the industry is workforce balancing. So, for example, transporting caregivers across a health system or things of that nature. Then last, in terms of delivery, again, this is not an exhaustive list, and I'd love to hear other thoughts people have on the chat or to weigh in on other use cases you're aware of, are things like delivery of pharmacy, durable medical equipment, or test kits, for example, to wherever those are needed.
So Jen, there's a question in the chat from Carrie Nichols about whether where transportation to employment might fit. And then someone wondered whether it would go in that last non-medical bullet.
Yeah, thank you, Carrie, and agree, Mary Ellen Rose. So we think about programs in terms of access to food, access to jobs access, right? Those are some important that I would input in non-medical. On the next slide, we'll talk about the Medicaid home and community-based waiver services, for example, that some of those have jobs access components. So I would absolutely put, we all recognize income insecurity and access to employment is crucial for health status. And so I would include that in the non-medical category. And yes, thank you. DME is durable medical equipment. So making sure that folks can access the things that they need for those supports. Any other questions?
Jen, I saw one more in there that was asking about medical appointments and whether that's inclusive of dental and or behavioral therapy. In terms of my definition, yes. In terms of the Medicaid and EMT definition, that is very dependent state to state. But we can kind of get into that a bit more in the kind of core program section about where these programs go and what they cover.
Absolutely. And Alex and I could talk about that all day because just of the the impact of Medicaid and EMT on this, of what exists, that so much of it does get down to that every Medicaid program is so different in terms of those types of trip destinations. But certainly, for example, in the rides that we do at Lyft, we know that we are able to provide access to those types of care locations in the various programs that we support. But again, highly program dependent.
And then there's 2 questions of whether a grocery delivery might be included. And and that was yes. So yes, Jen.
Yeah.
And then I guess you're seeing the chat too. And then what about companions with rides?
Yeah, absolutely. So, and why don't we just go ahead? We could go to the next slides as well, just so I can orient this around the different programs. So definitely food delivery. I should have had that on the previous slide. Is something that has come about. CMS has very specific guidance on programs that can provide that. Certainly within Medicare Advantage, we've seen more of a proliferation of some of that, but there are some waiver populations and other populations within Medicaid. We also know there's clearly a very close eligibility tie-in between SNAP and Medicaid, so those are still a bit distributed from a program perspective. However, we recognize that from just an individual insecurity needs perspective, that absolutely food access and transportation access, something like a food delivery, can be very crucial for individuals. And then let's see, there's a question about riders having companions. In many states, from Courtney, in many states that is currently allowed under certain government funding models, yet not in others. Yes, I think in Medicaid non-emergency medical transportation, for example, that first row, caregivers and companions can be allowed, for example, for minors. And if, for example, the Medicaid enrollee is a child, then their parent certainly, or for someone who may not be, cognitively or physically appropriate for a mode of transportation, as Alex said above, that if they have a caregiver or a companion to support. So yes, again, highly dependent across states. Helicopters for emergency transport. Absolutely. It is not a ride for Lyft, but it is definitely a mode of transportation within Medicaid NEMT. If you actually look at Alaska's spend for Medicaid NEMT, there's a fair amount that goes to helicopter, which is probably unsurprising. Have I gotten to all the chat, Sarah and Alex? Keep me honest.
So there is one question that says, seems like this assumes a person is insured. Is this correct?
Great question. So this first slide is a lot of payer driven. However, on the second slide, there'll be more examples where there is some other benefits that aren't necessarily linked to payers. But I would say, so yes and no, and we can go through those program by program if that's helpful.
And then one more, so Mary Ellen's asking a practical question about whether we can expand the slides so we can see the references at the bottom. It might be a little bit late to do that now. Mary Ellen, what we'll do is make sure all these references are posted. Any reference from this presentation will become a reference on the Confluence so that you can access those at any time.
Well, great. So I'll start going in on the programs, and then as the chats come through, maybe Sarah and Alex, just feel free to help keep me honest. So I'm trying to stay oriented on the slide. So in terms of programs, as we've alluded to, both Alex and myself, Medicaid non-emergency medical transportation, which has been around since the inception of the program in the mid 1960s, is rides to medical appointments for Medicare beneficiaries who are eligible, given that they do not have another mode of transportation available. As has been cited, each state program administers that differently, from everything from how they select vendors, whether they use vendors or not, how the screening and eligibility is propagated, even things like prior authorization for those rides. If you think about the scope of this program, there are 6.7 million individuals enrolled in Medicaid as of May 2020 per CMS. Of course, not every single one of those beneficiaries utilizes this benefit. So it really is up to that subset of the population who is eligible and actually takes advantage and uses the benefit as needed. In terms of funding, I think there's a lot of programs where there's not clear funding. However, for this, there is a lot more clarity that we have seen estimates of about $5 billion in total spend for Medicaid NEMT. That was last coming, in 2019. And that is separated between $3 billion of federal funds and $2 billion of state funds. Sarah, do you want me to keep going through the programs, or should we take questions as we go through?
I wonder, for the sake of time, because this slide with all of its subdivisions will be posted on the Confluence. I wonder, for the sake of time, if we should cover the next slide, and then, because I think we're current on questions, because Alex answered Courtney's question, and
Okay.
And then Lucy asked a framing question. Is it helpful? You can read that maybe, but maybe to get to the next slide just so we can see.
Yeah, I think there's a few probably important things on this, Sarah, that.
Okay, carry on then.
Cool. So I think just in terms of self-driven versus drive yourself, when you think about something like Medicaid NEMT, you have gas reimbursement as an option. And that'll be the same as like VA as well. So you can think about any mode of transportation typically being available under these programs. whether that is public transit, a taxi, a rideshare vehicle, an ambulance, a stretcher gurney van. There's a wide range, and that can certainly include things like gas reimbursement, even for self or other who's driving, again, dependent on the program. So yeah, I won't go too much into the Medicaid waiver transportation or the value add. I think you can see the numbers of impacts there. I think the big thing to highlight with those programs is that those are not necessarily constrained to trips to and from medical appointments. So in HCBS, for example, those can go to non-medical destinations such as jobs. And when per state regulations, managed care organizations and Medicaid can provide additional transportation for beneficiaries, they may also be able to flex the end destination dependent on that program. What I wanted to highlight before we go on to the next slide was Medicare. So we've talked a lot about Medicaid, but in terms of Medicare, there is no benefit in Medicare Parts A and B for kind of this non-emergency medical transportation. Certainly there's ambulance benefit. However, Medicare Advantage, so that should say Medicare Part C, I don't know why that says Medicaid Part C, can adopt transportation as a supplemental benefit. So if you think about overall, we have 25.3 million Medicare Advantage enrollees as of September 2020, 44.6 million traditional Medicare and those with MedSup enrollees. And out of those, only the MA members may have a supplemental transportation benefit. And out of that, 5.6 million MA enrollees are estimated to have some sort of transportation benefit. I think one other item to highlight for Medicare Advantage is that number one, it's not only trips to and from medical appointments, and furthermore, these can include wellness or social rides. So a shining example is trips to and from, for example, the Silver Sneakers benefit, right, to the gym for some social interaction and healthy activities. And also CMS allows some tailoring of Medicare Advantage transportation benefits, other supplemental benefits based on targeted chronic conditions or even like special needs plans. So with that, I'm happy to go to the next slide.
Sarah?
Yes, hi, Lucy.
Yeah, I think it's I think it's really important to highlight that the transportation benefit under Medicare Advantage exists solely because there's a financial incentive to think about it. So as we continue to think about transportation, or indeed any other invitation, any other intervention that's going to overcome barriers for people, we mustn't forget that when there's a financial incentive, things change.
Wise words, Lucy. I agree. I hear you. Thank you.
Great.
It's not like they thought it was a great idea.
Yeah.
Okay.
Noted, Lucy. Yeah, I hear you. I really
Thank
do.
you.
Thank you.
Yeah, appreciate that. I think there's certainly been a lot of work in terms of social isolation in those populations and trying to understand where the benefit is used to. And typically it's not always to medical appointments. So it could be to other areas of individuals' lives. So on this next slide, and really all we're trying to do is capture where dollars are spent today that are at the intersection of transportation and health, not necessarily kind of weighing in on the program itself. But for the first line, another large program at the intersection of transportation and health is the Veterans Administration beneficiary travel. So there are 9 million veterans in the VA system. Again, you have a subset of population that's eligible from the last, federal statement that was a spend of about $1 billion in 2019 for beneficiary travel. As was pointed out earlier, this can cover the range of things such as car, plane, train, bus, taxi, light rail, etc., or other special modes of transportation. This is approved for healthcare appointments within the VA system. Next up, we have healthcare delivery funded transportation. I think one of our upcoming SMEs will represent this viewpoint, so that'll be fantastic to add on. But health systems and those within the healthcare delivery sector can also fund trips themselves. So oftentimes this manifests, at least in inpatient settings, for things like an inpatient stay or an emergency room discharge, or guardians in health systems, other trips across outpatient and ancillary providers. Then we've talked a lot about payers who are funding this, whether it's the government or through health plans. Then we've talked about certainly the VA as a huge care delivery and entity, and then health systems. But then, of course, as Alex referred to at the beginning, we have community transportation and paratransit as well. So these are infrastructures available to provide general mobility, which can certainly provide access to healthcare, and other destinations. We recognize that funding comes from transit agencies, federal, state, and local, across those. And then the last, this would get back to the question earlier around, is this tied to insurance status? I think, that first slide, absolutely. The first row on this slide as well. But in these last four, not necessarily. And certainly, we've also seen a lot of not-for-profits step up. For example, the United Way Ride United program, other nonprofits providing rides to specific care or for their beneficiaries, which is often through grants, fundraising, and philanthropy. I think that is all we had, Sarah, I believe.
Oh my word, that was amazing. Alex, any thoughts?
Well, Jen covered those incredibly well given the short amount of time. I know we even went over. Sorry, there's just so much here. I think the main thing that I would just want to add before we switch is just, Jen and I are also very aware that transportation in particular has a huge divide in how it is provided, how is it accessed, all of those things between urban and rural settings. So I just want to make sure that that doesn't get lost, because I think that's going to be a key part as well in our discussions as we move forward, and acknowledging that different parts of our country experience transportation in very, very different ways. So I think that's the only thing I would end on, but otherwise, I know we've taken up a lot of the call time, so I can turn it back over to you.
No, I think it was a really wonderful overview, and I think this is actually a perfect amount of time of the call taken up for this kickoff. So grateful to have you both. Oh my God, we're so lucky. Any thoughts on the presentation going forward? Again, I definitely appreciate Alex's rural versus urban perspective. We're getting a nice point on that echoing. And then someone's asking if the slides are going to be available after. Yes, the whole presentation is recorded and on the Confluence. So for review at any point in time. And again, we promise to get those references in the reference list on the Transportation Confluence as well.
Sarah, this is Evelyn. One thing I just want to emphasize for the community, I think it was very powerful that the SMEs went through all those programs. Why that's important is because we have these core programs across the country, and each one of them is collecting or requiring transportation level data differently. Why we're doing this is because we want to standardize. We have a consistent way to capture this data, and we need through this process, so this domain is very exciting, is just to recognize the diversity of programs out there that are available that define these all differently. And so our objective is to get to agreed upon data set that then, one of our success factors as part of the Gravity Project is to inform programs. And by that is saying, how can we influence the use of standardized transportation concepts across all those programs Jen just walked through?
Excellent point, Evelyn. Fantastic. Again, you're going to hear the voices of Alex and Jen over the course of the next weeks. Incredibly grateful. We have another subject matter voice coming shortly. We're always available for questions, and thank you so much. I'm super psyched. I'm just going to quickly we actually don't have very much to present, and then we turn it over to technical updates at the top of the hour, I think, Evelyn, correct? So next slide, please. Just going to remind folks that we want to submit our transportation concepts. With that, all that conversation and presentation primed, submit your concepts so we can have a really robust data set to present to the community when we meet again in 2 weeks. Again, great presentation. True, it's amazing. Next slide, please. There's the link to submit data concepts for transportation. Next slide. And we've already addressed questions, so I'm going to keep on trying to go through. Identify inadequate housing. So the inadequate housing domain, it definitely is a little slim. Keep on going. Next slide, please. We've had, this is the total number of submissions. Again, it's difficult because we had so many submissions that rolled over from our previous domains. Next slide. So again, these are the way we frame our submission framework. So we have screening tools, assessments and diagnoses, goals of care and interventions. With interventions, we're looking at program names and definitions, providers and practitioners, and activities performed. Next slide. These are some of the tools we've collated so far. The American Housing Survey from HUD, Naruzaman, or the Medical Legal Partnership Tool. This is part of the Accountable Health Communities tool. We have the Medicare Total Health Assessment, and then the Upstream Risks tool. Next slide, please. Again, this is the way we're framing housing diagnoses as it stands. We have so far agreed upon the framing, and we did have a meeting with HUD. And although they can't formally say that they approve it, they had no objections. So they're in agreement so far with our direction going forward, which is really lovely. Next slide, please. So far, the goals we have represented: housing security, access housing resources, and functional housing. These are under really deep dive review because we are working very closely with 211 San Diego on this data set right now, identifying that it really needed a lot of robust analysis. So 211 San Diego is taking a look at it from the intervention and referral network pathway, and from the 211 body of knowledge, and from the community information exchange body of knowledge. So hopefully it's going to get added, it'll get more robust very shortly. Next slide, please. We do have some core interventions, housing repair vouchers. We have all of our counseling care plan codes that have rolled over, and then home repair programs, and home assessment programs, and home safety education. Yeah, so Lucy asks, can the thought be as varying by age? Olders may need housing interventions not needed by anyone younger. So for the purposes of this work, we have separated the unique interplay of individuals and age and ability from inadequate housing. So we identified some folks to help us with that, because there are certain accommodations that are not necessarily related, that are not in common with all users. So we have a whole little subgroup coming that'll work on that. Absolutely, Lucy, 100% agree. And not even just by age, even just by, you know, ambulation capacity and, you know, different needs of different individuals. Next slide, please. So the work here, again, folks are inadequate housing, is to just keep on submitting concepts. We enter into end-to-end review at the next meeting. So that means that, and hopefully with all of the robust additions from 211 San Diego, if you think it looks slim, it does look slim. So we're basically, inadequate housing is slim, sandwiched by two incredibly robust data sets: housing instability and homelessness on one side. And then I'm assuming, based on our amazing SMEs, transportation is going to be pretty robust as well. So please help us connect with and add inadequate housing concepts if you're able. Next slide, please. Just a reminder, we've gotten, I think, just 2 comments on the data principles. Next slide. So we did come up collectively with data principles in the Technical Advisory Committee. We're presenting to them to the community for review. You can access them on the Confluence, and we again just look for comments. So we're integrating some of the comments we've gotten so far. In some sense, perhaps the lack of comments means folks are in agreement, but it'd be great to get a few more just to make sure that folks think that we're on the right target. Next slide, please. Again, the principles as created are: number 1, improving personal health outcomes; number 2, improving population health equity; number 3, ensuring personal control; number 4, designing appropriate solutions; number 5, ensuring accountability; and number 6, preventing, reducing, and remediating harm. Lucy's asking if we're going to vote on the principles. If not, what is disposition? We will vote on the principles. We're asking for the same kind of process that we use with our collective domain data sets. So we're asking for review first, and then because they're principles and guiding principles, we're disseminating them through the different committees. And then, so the community here will vote, and then each of our committees also will have a chance to vote on them. But yes, consensus voting is the goal, as it is with all Gravity deliverables. We all have a voice, and we use consensus voting to make sure things are complete and agreed upon. Just a reminder, please try to vote in the housing instability. The only thing we're voting on right now is that housing instability and homelessness data set. All votes appreciated. Thank you. Next slide, please. Okay, at the top of the hour, 5 o'clock exactly. Amazing. We are now going to segue into, is Bob on the call? Evelyn, do you see Bob as a chat member?
He's on. He said he would be wrapping up right at 5, so he should be on when he unmutes himself.
Okay, fantastic. So we are now going to segue into a report out of the Connectathon that happened last week. I'm going to be passing the mic from from the terminology wing to the technical wing. Because the homework for terminology is at the end of the slide, Bob, are you unmuted yet? Okay, I'm just going to remind folks of the homework as it stands until we get Bob's voice, until I hear his voice. So the homework as it stands, if we think about the presentation, is to, number 1, vote on the housing instability and homelessness data set. Number 2, submit concepts for transportation. Number 3, submit concepts for inadequate housing. Number 4, to submit any end-to-end review comments on the data principles. So all of this homework is posted on the Confluence so people can find it. But just as a summary before we segue, because usually the homework slides are at the end and I don't want terminology people to miss it.
Okay.
Bob, you with us?
This is Bob. I'm back.
Hi, Bob. Bob is back. So Sarah DeSilvi signing off, handing off. I'm going to remain present, but passing the mic to the Bob Dieterle, Technical Director.
Okay, Sarah, thank you very much. Really appreciate it. So I'd like to do 2 things. Number 1, go over a little bit of what we're doing again. This is something we've talked about before on the technical side of this and creating a fire implementation guide to support the definition and exchange of social determinants of health information, but also talk about what we did during the Gravity Connectathon at this last Connectathon last week, where we actually took some of the initial concepts and we put them to the test. So next slide, please. So as you're aware from our conversation before, if you were part of it, and if not, I'll make you aware now, we're recasting the implementation guide to not be focused on a single domain like food insecurity, but rather be a framework that can support multiple domains. So as Sarah goes through building up the domain model, if you will, for all of these different assessment of social determinants of health domains, whether it's food insecurity or housing or transportation, we can support them within the same framework. It really becomes a question of what are the value sets and some of the front end capability on how do we basically code a specific assessment tool, and how do we use that coding to go and create the appropriate indicators of how the member answered it or how the patient answered it, and then the health concerns that basically implicates or directly identifies. So we're looking at how we deal with surveys, fire questionnaires, and I'll go back and forth between the general concept and the things that are really unique to fire. Fire questionnaires and questionnaire responses are how we go and encode the idea of a survey or an assessment and the result of the individuals answering it. Creating health concerns with appropriate ICD-10 and some EdCT coding. You've been going through this as you were going through food insecurity, okay? So these are the diagnoses, although we're looking at them as health concerns to begin with the idea that with other input, clinical input, they would get promoted conceptually to problems or diagnoses. Representing goals as part of the social determinants of health care plan. In other words, what's the goal for the individual where we're trying to intercede? And then ultimately identifying the interventions or the requests for community services, and then tracking those to completion, measuring outcomes, which is something we really haven't spent a lot of time talking about, but the ability to go and say, have we been successful? And if we have, great, and being able to account for it. And if we haven't, how do we turn this back into another iteration of how do we intercede, or how do we do specific interventions? And then ultimately aggregation and reporting, both as individual and as aggregated data. And something we're bringing back into focus is the idea of consent. The individual consenting to share this information with whomever is appropriate in the community. Next slide, please. So what we have been focused on right now and focused on the Connectathon is how do we take a survey instrument and ultimately provide the capability to code it with LOINC, the questions and the answers, and have tooling that would turn that into FHIR questionnaires that could be administered through basically some kind of a survey tool. In this case, we'll have tooling that will show you how that could operate, and collect a questionnaire response and ultimately generate the things we saw down below: the questionnaire response, the observation, which is basically the answer to the question or the calculated result, and then ultimately the condition. And that condition would then feed into a process that the provider would be managing, evaluating the health concerns, looking at other clinical findings, determining whether these should go on the problem list or they should be considered diagnoses, if you will, and then ultimately specifying goals and interventions. So this is a process that we were working on. We were working on this with Regenstrief, looking at how we can LOINC code these surveys and add some additional capability to them, and then working with the National Library of Medicine on some of the tooling they have that will take these LOINC-coded surveys and turn them into FHIR questionnaires, and ultimately with some additional capability that we were exploring last week, how we can take those questionnaire responses and turn them into the observations and health concerns. So in other words, automated tooling to allow you to take a survey and basically bring it right into the workflow we're defining as part of this FHIR implementation guide. Next slide, please. We're also looking at creating a reference implementation. That reference implementation is intended to go and show how all of this would work end to end. From the survey to the observations, the health concerns, et cetera, and look at how we would exchange that with somebody on the other side. So how do we exchange these health concerns? How do we exchange these interventions? How do we go and account for round trip, making sure that the interventions have been completed, or if they haven't, to know that too. So the goal of reference implementation is to have examples of these, if you will, systems, one on the side of the provider, one on the side of the community health environment, to go and say, here's the kind of data we can exchange back and forth so that we can accomplish interoperability related to social determinants of health. Next slide, please. This is our work stream. The one at the beginning of this presentation was slightly off on times. I think probably just because of conversion. What we're doing is we're working for a January ballot for a standard for trial use 1. We have to have that work completed by the beginning of December, so it can go into the ballot cycle, which will be in December and early January. We'll be doing a ballot reconciliation probably out through April, with the intent of, and we'll talk about Connectathons in a minute, with the intent of trying to go to publication in May or possibly June, depending upon the feedback from the Connectathon in May. The reference implementation development cycle is between now and the end of the year, with the idea of having it available for the January Connectathon. We'll update, and we probably need to move the reference implementation outdate just a little bit further on this timeline, but being updated based on the ballot reconciliation we do. In other words, the feedback that we get from the community on that ballot, and as we reconcile how we'll address it, then we're going to, we believe, need to update the reference implementation to correspond to any changes that we make. At the bottom, we're showing 3 Connectathons, the one we just went through, focused primarily on the front-end process, automation of the survey process and creating the health concerns. And then one in January, focused on the entire end-to-end flow. And by the way, all of this implementation guide will be intended to support multiple domains. We will use food insecurity as an example, but not have anything constrained to it. And then ultimately to be able to do this again in May. That would be the final proof of the work that we have done. If it turns out we prove that we don't need to make any updates to the guide, then we'll go ahead with publication. If it turns out based on that Connectathon, we find something needs to be adjusted, then we would go back and make updates, do the process of adding in what are called JIRA tickets and getting those resolved, voted on, incorporated into the implementation guide. And that would probably move the publication out into June. Next slide, please. This is the information on where you can find the information on the Connectathon number 25 and the specific social determinants of health or gravity track. Next slide. Our objectives for the Connectathon were to provide an overview of the use cases, the multi-domain approach to social determinants of health, to demonstrate the use of the LOINC panels and NLM tooling and the structured data capture questionnaire and questionnaire response, to demonstrate how we can use, these are some very specific things, FHIR mapping language, structure maps, etc., quite technical, to and the FHIR validator to auto-generate the observation and the health concern. There were 3 of us are track leads, myself, Corey Smith, and Monique Van Berkham from the AMA. We were the track leads. We had a lot of support from the AMA. We had good participation from quite a few people. If you go to the next slide, you'll see how many. There were roughly 24 people that were involved from 18 different organizations. Some just came in to listen. Some were there to do some fairly deep things. So we introduced the general approach of multi-domain support and maintaining or designing and maintaining dynamic value sets. We introduced the idea to go and use the structure maps to go and automatically generate the FHIR resources that we need to describe the outcome of a survey instrument as well as the health concern that is implicated by it. And then we had good representation from both NLM and from Regenstrief. Clem McDonald participated. He was basically founder of Regenstrief, one of the early founders of HL7, and is one of the key people at the National Library of Medicine. So he was there to give an overview of what they're doing. He's very interested in working with us on this project. And since he represents the ability to go and talk for both Regenstrief and for the NLM, that's a very powerful figure to have supporting our work. We also demonstrate our ability to reuse structured data capture implementation guide for social determinants of health screening. Next slide, please. We had some lessons learned. We're going to have to understand how we can align the work we're doing in the social determinants of health implementation guide with what implementers are capable of, okay? Now, in many cases, what we're doing is we're kind of skating to where the puck is going. We're focused on FHIR R4, which is mandated by ONC as part of the certification process. So we expect all the major EHRs or all the certified EHRs to be supporting it. CMS has also decided to go and pick up the same baton. They have required payers to support FHIR R4, both for making data available from the payer to their member, but also for peer-to-peer data exchange. So we're really skating into where the industry is going to be, depending upon which of the milestones we're talking about. Some are as early as January this coming year. Some go out into basically the middle of 22 or the beginning of 22. reference implementations are needed. That's what we'll have by the beginning of, or by the next Connectathon, is a robust reference implementation to test against, regardless of whether you're playing the role of a provider or you're playing the role of someone in the community who's trying to deliver social services. The second point is just a technical one. We need structure map definitions for these various questionnaires so that we can go and ultimately create the health concerns. That could be one per question. It could be through as many questions as necessary to compute a response, which is a health concern, but ultimately to have the computational logic available to go and automatically create a health concern based on the individual's taking a particular assessment or using a particular assessment tool. We are noting these things are still maturing. We're going to use what capabilities exist in release 4 of FIRE. We can use that quite well. It's not mature, but it's reasonably mature. And where we find something is insufficient, we can add what are called extensions. And then in some future version or release, we can consolidate that back into the core of a FIRE resource. I think one note was we can't get rid of complexity, but we can move it around, and we certainly can mask it with appropriate tooling. Next slide, please. So what's next? We're going to continue to engage with NLM and registries to go and make this process that we were testing a reality and make it available broadly. We're going to continue to engage the community, as Sarah's been talking about, to establish the clinical content that's required. And then we're going to start the reference implementation development, and we're working toward the ballot submission for January. And please come and join us. The second week of October, we'll start having open community calls around the technology side. Don't know the schedule yet, but we'll have at least one call per week that will be open and available and tied into the HL7 process for any sponsored or project scope statement sponsored work. So I think that's the end of it. Questions or comments that have come up that I need to talk about?
I just want to make sure, so there's been a really robust conversation regarding outcomes and goals and time and the e-care plan work that is happening concurrently that Evelyn is part of. So do any of the questions on the chat relate to Bob's presentation, just to make sure that I haven't missed them? Can folks unmute themselves? So.
Evelyn, shoot. Well, I'm also joining the patient care group and looking and working with them as they continue to develop, enhance, and specify how to do care plans. The focus for the primary work in the implementation guide is literally going to be around social determinants of health, our ability to describe those. The care planning that Evelyn's involved with is broader. It's not just around social determinants of health, it's around a comprehensive care plan for an individual. So, I'm focused on one small piece of that.
So, Bob, this is Mike Link. I'm unmuting myself for a question that I know has been hard for our provider organizations in Michigan to kind of get their heads around. The idea of a concern, a problem, and a diagnosis being slightly different, and the further distinction between a screening response and a concern, problem, diagnosis has been a really, really hard thing to get across. And I don't know how much confusion you're seeing on your end when you're trying to tease out these concepts and as you're building this approach.
No, we're seeing exactly the same thing. I think what we're doing is we're seeing the evolution of provider platforms going from being something where it is purely clinical, purely driven by the provider, purely making their observations, to something that now is effectively shared with the patient and their concerns and the things that are relevant to them about how they wish to be cared for. And that's a transition we're making. The good thing is the fire resources already have that concept that a condition resource, which is how I express a diagnosis, can also be a problem or could be a health concern. So we have the ability to exchange it. The question is how it gets represented inside of the EHR. That make sense?
It makes perfect sense. I'm just remembering let's call it a spirited discussion that I had with a specialist at our institution who is very interested in the concept of problem lists, but seems not to be able to understand that, at least on the primary care side, some problems don't have a specific diagnosis when they're first seen. And so we were pretty rigorous back and forth in our arguing about the level of specificity you have to have before you can call something a diagnosis or a problem in an electronic medical record, and we couldn't ever resolve it. So this is, and this will be really interesting when we add people into this with their own ideas about their goals. So.
No, and I absolutely agree with you and understand. Can you back up to that slide, the one we did on the survey, the one with all the flows? Because we do recognize the problem we're talking about. I think it's 2 more back. Yeah, right here.
Yeah.
Okay. So what we recognize is that what comes out of the survey instrument is a concern on the part of the individual. It is their concern. Okay. You know, it's food insecurity, or it's I don't have access to transportation, or it's a housing problem. Those are real concerns. You know, they're not subject to somebody else's decision whether it's okay or not to have that concern. That's not necessarily a problem that can be addressed.
Yeah.
That's where the provider has to make the decision. It's something I can even intercede on. If there are no programs available, or the thing is really not something that can be managed, okay, it's a concern. It doesn't change the fact it's a concern, but it does change the fact that it may not be a problem that can be dealt with.
Yes.
Calling it a diagnosis is a whole different problem.
So Bob, this also goes along with our chosen framing through, you know, the Gottlieb and Alderwick lexicon, where you identify risks, but social needs, the difference between social risks and social needs. So a social need would be the thing that the person actually says, like, this is something I want to intervene on, whereas opposed to like the risk is the thing that's identified from screening. It looks like, so there's a couple questions in here. So Mike, I don't want to eclipse your question. Did that seem sufficient?
It's a great starting point. Yeah, we'll be coming back to this point many times over the next few months. So this is a
Oh, yes, we will. Yeah, this is not landed.
Absolutely. In fact, Bob and I have many a Sunday morning conversation about this already. So Lisa has some questions regarding, so Bob, can you see Lisa's comments? USCDI definitions will help us clarify the difference between problem list issues, health concerns, and encounter diagnoses. And then, so Lisa, do you want to unmute yourself and speak to that a little bit? Or are you able to?
I think I am. Can you hear me now, Sarah?
Yes, we can. Hi.
Thanks. Hi. I'm just totally supporting everything that Bob is saying here. I think that, you know, this is kind of a human problem, not really a technology problem, and it takes opportunities like gravity for us to all come together and begin to understand each other and share a common vocabulary around even things like, you know, problems versus health concerns versus encounter diagnoses. The progress that we're making in all understanding each other and the problem that we're looking at is really what will make it possible for the technologists to come along and implement what we are talking about. So I feel like even to understand, you know, Bob shows in this picture the health concerns, the problems, and the diagnoses, and to have a large group of people who can just even appreciate and agree on the distinctions and what's being drawn in this picture is what's really going to help us make progress.
Yeah, let me do a little bit of background for those that don't know me. I spent 16 years at the University of Michigan Medical Center. I have trained physicians. I've spent a lot of time doing clinical trials. I was Cerner's first general manager, so I've done the ER development. I have I have a fair amount of background both on the technical side and the clinical side. I am not a physician. I'll just say that right up front. However, I really appreciate the problems that physicians face, but I also appreciate the problems that we have in trying to make the kind of information we're talking about exchangeable. We have to have common syntax and common ways of expressing the information. And then we have to be able to exchange it in a common way. And so this is an interesting challenge. And as Lisa said, it's a human challenge. It is also a technical challenge, and the two of them have to work together to solve it. Other questions? Am I still online?
You are still online.
Okay.
I think
I had
it's
to ask.
evolving.
I've had internet problems today, so.
Oh my gosh. So this is actually a really good idea. So Nelson's asking, is there an evolving process to maintain a glossary for the Gravity Project? So we are a collective. That is a brilliant idea. And I think,
Sorry, we do have one. We just haven't updated it since we kicked off. We have a
oh, there we go. So Nelson, thank you for reminding us about something we already committed to and need to shed light on. So yes, and I think integrating these new clarity from where we are right now with the technical build is a really important part of that. So thank you.
So anyway, looking forward to working with all of you. This is an interesting problem. I think between Evelyn and Sarah and I and others, we've found a path that gets us to something that is implementable and usable in a reasonably short time without compromising the integrity of the process that Sarah has been putting in place with the community in generating appropriate code systems and value sets that describe the various aspects of social determinants of health. Anything else you need from me, Sarah? Or Evelyn?
Oh, I think this is lovely. I think we have about 4 minutes to go. And then Nelson's asking, especially by what we mean by health. That is, yeah. So trying to collectively agree on that will be interesting. I'm just going to run through. We hear you. That is definitely an important concept, and then an important one from the different lenses. I think about that brainstorming slide. Like at Gravity, we definitely try to take on and take off our hats, right? So I'm a clinician. I try to take off that hat, and we think about the patient perspective, the system perspective, the government perspective, and the community-based organization perspective. And my guess is the concept of health from each of those different perspectives is unique, but there might be an overlap again in that Venn diagram in the middle where there's something we can agree on. Update on the housing list, Mark, I don't know, but the homework and next steps. I don't know if Sarah B has an update. That would be amazing. But so again, submit your votes for housing instability and homelessness. And I'm going to go ahead and drop again the link. I really feel like this is like a funding thing going on right now. Everyone trying to call in right now and double your vote or whatever. And so submit your votes on housing instability and homelessness. And then submit concepts for transportation and inadequate housing. And then submit, we don't have in this slide, submit comments for end-to-end review on the data principles. And then Nelson, again, absolutely 100% true. Nothing matters much without a uniformly used concept of health. And again, I think the most important concept of health, again, would be that from the person themselves, the patient. And to whatever degree they lend their voice to each of those different perspectives is where the consensus lies. So work to be done on a glossary. So we're grateful for that. Any other final comments before we close this really amazing, robust, action-packed presentation? Any thought?
We got 3 more votes.
3 more votes.
Yeah.
Yay. Okay. So only 9 to go.
Wait, what did we begin with? Sorry. I'm looking at our slides.
we needed 92 votes. We started with 28, I think.
Oh, so actually, no, 28. We did great. We got 12. So thank you, everyone. Yeah. Sorry.
Okay. Thank you guys. Again, so transportation, an end-to-end review for inadequate housing starts next time. Transportation review. Grateful for all of your collective engagement, and we look forward to seeing you in 2 weeks. Thanks, everybody.
Thanks, everyone.
Thank you.